Hi, John Kanellopoulos from our center here in Athens, Greece, the Laser Vision Anterior Surgery Center, Clinical Professor of Ophthalmology at NYU Medical School, New York City, New York. A favorite subject, keratoconus. We're seeing here the Wavelight Alcon EX100 excimer laser, the tomography guided software. But let's go and look at this case in particular. This is a male patient over 50. So it's a myth that over 50 keratoconus does not change, because despite the fact that this patient is not a rigid gas permeable contact lens wearer, which would explain this epithelial remodeling, we can see on the total OCT, anterior segment OCT thickness map, that the cone is clearly evident. And we can see on the epithelial maps that it's an active cone. The patient either rubs his eye, it's the left eye that's worse than the right eye, or, and this is the more common reason for this, sleeps on his left eye, sleeps face down on his hands, and probably rubs his eye to find comfort from the allergic foundation that is evident with keratoconus. So we have an over 50 gentleman with active keratoconus. Let's go and look at the Pentacam maps. Clearly the cone bulging on the anterior elevation map on the Pentacam, and the posterior elevation map is more marked. Keratoconus is more marked. And why is that? Why is it that the posterior side of the cornea has more concavity than the curvature change in the anterior part of the cornea? Here, the thickness map again with the Pentacam. Let's go back to the epithelium, and this is the explanation. Because of the epithelial remodeling. The epithelial remodeling masks some of the anterior cornea manifestations of the cornea, and that's why we have advocated that the epithelial maps are a more sensitive diagnostic tool than the curvature maps, because in the beginning of the disease, the epithelial remodeling can mask the cone from all our topography or even tomography measurements. So we're going to go to the treatment plan here, and we will focus on this image here. And what we will treat here with the topography guided software is the refraction is -9, -6 at 130 degrees. The topographic data shows a similar cylinder at 124 degrees, and we have shown and reported that we will treat this axis because the refraction is not that reliable in the amount and axis of astigmatism, because the patients can find a different level in the cornea to refract from. Of course, we cannot treat this refractive error in the cornea that has a minimum cornea thickness of 483. So we will opt here to treat some of the cylinder. So we will go with cylinder. Our max is usually 3 diopters. So we'll treat 3 diopters of cylinder, and we can see how this will change. By the way, this is the, that was the topographic correction without any refraction. So let me go back and let's look at that again. So if we have 0 refraction, and some clinicians have advocated that let's go and do 0 refraction. So this is a 0 refraction topographic normalization of the cornea. So we're going to treat 3 diopters of astigmatism, and here we go, 3 diopters of astigmatism, and we'll treat some sphere as well. We have some residual stroma to work with, maybe a -3. So we'll do a -3 at 124, so we can all appreciate we're way far from the spherical equivalent that is a -12 in this patient. We're doing a spherical equivalent of -4.5. And this is all we can do. Of course, outside the US, we can go down to the optical zone of 5, increase the transition zone. In the US, we cannot do a 5mm optical zone. We can go with the Contour software only down to 6 and a transition of 1.5. So this, of course, will remove less tissue, significantly less tissue. We're going to be removing centrally only 60 microns, so this is very important. And we'll couple this with a PTK, which is also something that's not available in the US, that we will treat in a diameter of 7.5 millimeters, 50 microns, to remove the epithelium and use the epithelium as a masking agent for the correction. And then follow with what we have introduced as higher fluence, 6 milliwatts per centimeter squared for 15 minutes. So this is in essence the Athens protocol design in our laser center live today. Thanks so much. This is John Kanellopoulos. We'll return with the data from this patient a couple months later.